Let's first see if
Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend this time with us. We are going to have a repeat performance on a topic that is very important. I can't tell you how many cases I see in my work where preventable amputations are occurring. So I'm very happy that we are repeating this program. But without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
thank you very much, Dr. Neighbor Stevens, and Dr. Hines and Dr. Walks won't be with us this morning. Before we start, I want to introduce Dr. Richard Allen Williams, and he has a few words he'd like to say before we start. And Simon, if you can show that flyer that he had, please. Dr. Williams,
I'm here.
go ahead.
Good morning, everyone. Good afternoon.
Good afternoon.
Go ahead,
Is the
Williams.
slide up? I don't see it yet.
Simon, can you show that slide I sent you on the Imhotep?
While he's doing that, may I say that I'd like, if possible, to engage with Simon for our upcoming Imhotep Gala Awards. We need someone with his expertise to work with us on the videography and the AV. So, Simon, if you're hearing me, please make arrangements to contact me through Dr. Maxey. We need your help.
Okay, go ahead with your announcement, Richard.
So, pardon me?
Go ahead.
He did not hear.
Richard,
It
proceed.
looks like the, okay. Well, again, good afternoon, everyone. I'm proud and happy to be here on the Black Health Trust. And again, congratulating Dr. Maxey and all the participants in this monumental community effort that you're making to bring as much information to the minority community on health issues as possible. Today, you see that we have on the screen a Minority Health Institute event, which is called the Imhotep Awards Gala, a tribute to Black physicians. And that is coming up on December 13th. We appreciate Dr. Maxey making it this time available to announce this to everyone on the show. And we hope that you will scan the QR code on this on the screen so that you can get your tickets to come to this monumental gala, which is for the purpose of recognizing the contributions and sacrifices that Black doctors have been making, which have been unrecognized. It is going to be on Friday, December 13th. Dr. Maxey, in fact, is one of the Imhotep awardees, as are several other Black doctors in the LA community. We hope that you will come and share this with us and give support to the idea that Black doctors do count, that we need more, and make certain to recognize these doctors who are being honored. The event is being chaired by John Bacchus, who is the CEO of LA Care, and the keynote speaker, and also one of the honorees, is Dr. David Carlisle, the president and CEO of Charles Drew Medical School. We want to make sure that everyone gets this word. Again, this is less than 2 weeks away. Please scan the QR code, get your tickets to come to this event, which is going to be spectacular, and will be held at the JW Marriott Ritz-Carlton Hotel in downtown LA Live. That's it. Any questions,
Dr.
Dr.
Williams.
Maxey?
No, thank you very much. I appreciate you, as always.
If you could, please show the slide again so that people can scan that QR code, because it's off the screen now. Can you do that one time?
Okay, if Simon can do it. Simon, can you do it? I think it's up now, Dr.
Okay, and please scan the QR code, folks, and come and join us for this program.
All right, thank
We'll
you.
see you on Friday, December 3rd.
Okay.
Thank you so much.
And Simon, I think
Bye-bye.
Dr. Gibson sent something on the chat he wanted you to show with a link in the chat. If that can be done, then we'll get to our program. I'm sorry. So while he's doing that, I have a little bit of news I just want to put out. I had some sort of sad news. One of our people who supported the Black Health Trust for years, who calls in every week from Cape Town, South Africa, Dr. Hal Walker, unfortunately passed yesterday. He was 91 years old, and we give our sympathy to his family for his and condolences for his passing. And I also have some good news. Another long weekly supporter of the Black Health Trust, John Sudukas, called me and he told me that a couple of months ago he made 91 and he's doing well and excellent. And we wish him continued good health. He's someone that has been in the music world for a long time with Aretha Franklin and all the notables that we know about, the founder of the Newport Jazz Festival, and all the jazz festivals you've heard about. So with further ado, Dr. Neighbor Stevens was going to present our lecture for today. Dr. Edwin Kendrick, if you can start that, Simon. Our key advisory members who served in office as that are disciplined in the way to save these limbs when possible and appropriately diagnose and treat them. And we have as a speaker today one of the leading experts in that area, Dr. Edwin Kendrick. And as we said before, he is the president of the Charles R. Drew Medical Society, which is an affiliate of the National Medical Association. He's a vascular surgeon in private practice. He's the founder of the Sano Vascular Group. He completed his vascular surgery fellowship at the University of Maryland Medical Center. His general surgery training was done at Tennessee, at Memphis, and also at Morehouse. He also has an MBA, so it means he can count some nickels and loan me some. He also has an MBA. He's an accomplished physician, and we invite him with joy to the Black Health Trust. You have the floor, Dr. Kendrick.
Thank you so much, Dr. Maxey, for having me, and to Black Health Trust for having me. It's an esteemed honor whenever you're invited by Dr. Maxey to come and share insights with the community. I feel that it is not just an honor, but it's a responsibility for me to do this in settings like this, as well as in the community. I want to thank everyone for coming, and I'm here for you. That's number one. Number two is that I hope that the information that you obtain today is actually dispersed within the communities that you live with, family members, because this is information that's not going to be easily disseminated, but it's information that we need to know about. And so just give me a moment and I will bring up my slides in just a second. But again, I'm very grateful for the opportunity. I also see people that are all across the nation here, and I want to recognize people that are in Florida, in New York. I think people mentioned Tennessee and or Maryland, and California, of course, and people that's also affiliated with the Charles R. Drew Medical Society. But I do want to thank everyone for coming out today. So we'll go ahead and get started. Again, what you'll see is the logo down at the bottom, Sano Health Farm, which is a nonprofit for advocacy, research, and mentoring, and there's a lot more that you can find out at sanohealth.org and some of the work that we're doing across the U.S. But today we want to talk about prevention of unnecessary amputations. The goals for this talk are several. Number one, we want to define peripheral arterial disease, or shortly we refer to as PAD, for peripheral arterial disease. I want you to know what the PAD risk factors are. We want to talk about reasons for amputation. We then want to talk about how to detect peripheral arterial disease. And then the last part, we'll talk about misdiagnosis and myths that can cause harm when it comes to arterial management. So this is how we begin, right? On the left side, this is what we love. We want to see a blood vessel here, has 3 walls to it. You can't see all the walls, but there are 3 walls. Here are red blood cells, and they're actually traveling through a healthy blood vessel. So this is where we start. Our goal is that we don't want to end up here, but all of us will at some point develop this yellow stuff here. This could be plaque, it could be calcium, it could be old fat that has been there, it could be a lot of different things, which we'll talk about. But the problem here is we don't want to end up where all of that yellowish kind of material gets so narrowed that it stops blood flow from moving through the blood vessel. Dr. Maxey talked about ischemia, and what that is because these red blood cells you see carry oxygen. We want to make sure that that oxygen gets through these arteries that are carrying blood flow to things like the fingers, the toes, as well as the brain, as well as blood vessels to the heart. What this does is reduce our risk for needing an amputation due to dead tissue, needing surgery on our neck, and also decreasing our risk for stroke and heart attack. So what we're talking about again is where we begin and where we start. And one of the important things that you'll note is inside of this blood vessel, here's where we start. But here's where we actually are. You can see again the red blood cells here, but you see these yellow little dots here, okay? These yellow dots can actually, or circles, can symbolize anything from sugar. So people with diabetes, you can have excess amounts of sugar floating in your bloodstream. It may resemble fat. So this could be high cholesterol that could be in a person. It could resemble chemicals, such as people that smoke or vape get all kinds of toxins. It gets inside their blood vessels. So it could be a number of things. Most importantly, it could be inflammation. You say inflammation? Absolutely. So inflammation can also cause problems because we know that if you have high blood pressure, or people that may have rheumatoid arthritis or lupus or scleroderma, any type of rheumatological disorder, you can have factors floating within your bloodstream. And all of these little yellow circles, right, what they symbolize can actually cause injury to this red wall that you see around here. And over time, those repeat injuries, long-term, can result in things like collection of fat, long-term calcification. It may result in so much inflammation that you narrow this blood vessel, and so it will clot, or it can completely become blocked, or what we call occluded. Now, if this was to happen late term, remember I said that these red blood cells that you can see with the green arrows carry oxygen. So now the oxygen is not able to get through this blood vessel because of all this chronic inflammation, scarring, and damage from all those chemicals and other items that you see here in the blue: sugar, fat, chemicals, and inflammation. So our goal is we really want to be focused on this area, because if we can focus on this area and control this area, our hope is to maintain a healthy blood vessel so we can avoid this end disease. One of the things that you'll notice at the bottom of some of these slides is I say PAD progresses with age and health condition. And that is something to remember. Again, these are the health conditions, but no matter, as we continue to travel through life, with age, we have a higher risk on developing what's over the right side of the screen. Again, a little bit more background information before we delve in. Here's what we're talking about. Our ability to control risk factors that we talked about earlier. The number one way we can do that is if we don't have any health conditions. And in California, where we tend to see a lot of people on supplements, they'll even take supplements, whether it be turmeric, to try to decrease inflammation in the body. Number two ways we can maintain this kind of state is to control our health condition, whether it be diabetes, high cholesterol, so taking our medication, keeping those disease processes under control. That includes borderline diabetes. Why? Because we know that even with borderline diabetes, you're still at risk for developing complications related to arterial disease, which could be stroke, risk of limb loss, risk of heart attack, risk of kidney disease. And so, most importantly, how we can also maintain this state is with an earlier diagnosis. If we can diagnose someone earlier that has this kind of condition, we can try to maintain their blood vessels looking like this rather than moving over into a later stage where you start getting the fat, the calcium, the clots, and the blockage. When we start talking about late stages, it often can be from a misdiagnosis. Someone that never got the diagnosis of arterial disease or the narrowing in the blood vessels. It could be due to someone never ever receiving treatment or getting treatment too late for their diabetes. Maybe they had their diabetes for 10, 15 years and it was just uncontrolled and they didn't know they had it. Or it could be someone with a known condition that is just not controlled. And so it's also very important that if you're having health conditions, don't just tolerate that your blood sugars are out of control or your high cholesterol is out of control. We have to be active in making sure that our providers are getting our health conditions under control. Now, what we know about diabetes, Anthony Anderson, an actor who's actually a spokesperson for Novo Nordisk, they've advertised up to 4 times a greater risk of having a heart attack or stroke with diabetes, and we talked about why. We also talked about high cholesterol, and you can see again, normal artery all the way to an artery that becomes very narrow. Again, circulating high levels of cholesterol. Smoking, the toxins from that causing the same problem. And again, we talked about hypertension, we talked about inflammation. So again, normal artery wall, you get inflammatory cascades or inflammation inside your blood vessel, those circulating yellow circles we talk about, it starts to damage the blood vessel. And that's again what you get, whether it be hypertension, whether it be rheumatologic problems, like you see someone that may have lupus or rheumatoid arthritis. All right. These are all problems that can result in problems with your arteries. So the question when we start talking about road to saving limbs is there's two different pathways we can take. There's the easy street, which many times can be the shorter route towards an amputation, or the better way, right, which can lead us a longer pathway to avoid amputation as much as possible. And it's not just amputation, it's saving lives. That's why we put here saving lives, because most of what we talked about so far has been saving lives, not necessarily limbs. What's important is if you look at the communities around the world, does anyone know what the most common cause of death is? It's actually cardiovascular complications. And so that's heart disease. You can put into their stroke, okay? And so kidney disease, kidney failure, these are all problems that stem from hypertension, high cholesterol, and those other risk factors we talked about. So if we talk about amputation, what are the most common reasons for amputation? Well, let's see. Foot infection. That's one of the most common causes, and particularly in patients that have diabetes. So you may see family members that may have little cracks or fissures in their skin that you think may not be a big deal. But if these get infected, this can even be over the base of the foot, where the great toe is hitting against and callus against the concrete or the bottom of the shoe. This can cause little cracks and fissures. And if these get infected, many times the patient may not know. This is a good reason why we talk about diabetics, because they have a low immune system, so they're more prone to infection. We talk about checking their feet, because this is one of the most common ways that we see infections, and it's in diabetes. And many times the person with diabetes don't realize they have an infection until it gets too late. And by that time, when they show up at the hospital, it's usually in the worst stage, and it's difficult to save them. So being able to assess your foot, getting good foot care. What I recommend a lot of times of people that are prone to having ulcers or sores on their toes probably should start using some really cushioned shoes. I prefer Crocs because it doesn't tend to put a lot of pressure on the front of the toe. But having a good orthotic, so talking to a podiatrist about something that can fit in your shoe to stop excess pressure on the foot is important, as well as stopping your toes from actually being injured by being in very tight shoes. Here's something called rest pain. Now, what we're talking about is arterial disease. And again, in arterial disease, well, let's say, first of all, why are we even talking about arterial disease? The reason we're talking about arterial disease in an early diagnosis is because if we can detect the narrowing in your arteries in the legs, that's usually the most early sign that someone has a risk: heart attack, strokes, kidney failure, okay, and then loss. So by detecting the disease sooner in the legs, we can often put people on risk factor modification. But in rest pain, this is a late stage. This person already has severe narrowing of their blood vessel. And so when they're lying in bed at night, the reason we call it rest, because that's what you usually do in bed. And in bed, they may have cramping of their toes, cramping in their foot, and they may have to dangle their foot off the bed and massage their feet to try to get relief. So this is a more severe stage of peripheral arterial disease. And if you start to get sores, it's a critical stage where these people need surgical intervention as soon as possible. So you have rest pain, this is a serious sign, and many times these patients need urgent surgical intervention, particularly with sores. What you also see underneath that finger is a little bulge, okay? And we'll talk about that. And matter of fact, this looks like the skin of a Black person. So we'll talk about that as well. But I want you to notice that Rest pain. I want you to notice this, looks like a varicose vein here. I want you to notice some swelling around the ankles, and we'll talk about this in just a little bit. What's going on? All right, claudication. Now, oftentimes on television, it's like, can you really trust what you see? On television, when they talk to us about arterial disease or narrowing in the legs, they often talk about claudication. What they often say is if you have symptoms of walking and you're getting cramps and pains in your legs that require you to stop and rest, you may have PAD. And if you do, go see your doctor. And so here's someone that's actually walking, they're having cramps in their legs, they need to stop, they recover, their legs feel better, and they tend to walk again, probably about the same distance, and they have the same condition. That's called claudication. The question is, people with claudication, do they need surgery? The answer is, most times they do not need surgery at all. Now, I want to say that again. People that are diagnosed with claudication, do they need surgery? Again, oftentimes they do not need any surgery at all, and they actually have the lowest risk for amputation despite them having cramps in their legs. I'll say it one more time. Do people with claudication, do they really need surgery? And the answer is no. Why? Because we know that the people with claudication, if we put them on risk factor modification, that means medication management. Maybe it's cholesterol-lowering medications, medications that decrease inflammation, and they actually have a healthy diet and exercise, their arteries will actually start to increase in size, delivering more blood flow to their feet. And so they tend to be able to compensate for the narrowing in their arteries. These patients, again, are at the lowest risk for having an amputation. So the question becomes, well, I know a family member that had this very problem. Why did they get an operation? Well, I'll tell you. The main time that we operate on people with claudication is because they have difficulty moving around. Maybe they're doing daily activities or working. So if you have problems shopping in the grocery store, you have problems moving around your house, you can't do activities of daily living like cooking, all right, cleaning the yard, that may be a reason why. Also, if you're working and you can't walk, you need to walk at least a mile a day, but you can barely walk a block, that's a reason to have surgery. But outside of that, these patients really do not need surgery. And as a matter of fact, outside of the medication management, that also includes a medicine that can actually double your walking distance. So there's a medication we can give to people that can make your red blood cells a little slippery, and you can actually increase your walking distance over time. And we talked about by increased exercise, you can dilate the veins, dilate the arteries. Now, I have a very good example of this. I had a patient that came in with claudication, and she actually mistook the information. I said exercise 3 times a week for 45 minutes a day, and she thought I said exercise 3 times a day for 45 minutes. Well, by the time she came back in, guess what happened? Her symptoms were gone, okay? And we see this all the time. So this is something that's actually feasible. Now, here's the problem. The reason why I talk about it is based on this cartoon here. The doctor asks the patient, says the patient, all your labs are back. They show a serious overuse of unnecessary and inappropriate tests and procedures. This is what we see in claudication. We see a lot of patients with claudication who are undergoing unnecessary surgery, surgery they do not need. Now, let me ask you a question. If you have a blood vessel that is intact, meaning that blood flow is flowing through it still, it's getting through, maybe a little difficult at times, but it's getting through. Now, what if you go sticking things, wires, and you're tearing up the artery to try to open it up and putting stents in place? What do you think's going to happen? At some point in time, with all that injury to the blood vessel, we know it's going to scar. And that scar inside the blood vessel over time can start to narrow it again. And so every time you undergo a surgical procedure, there's always the risk that it could get worse and lead to, guess what, an amputation. And what we said is that our goal is to not take the easy street. We want to take the better way. And the better way is making sure that if you have claudication, before anyone touches your legs, you have to make sure, are your symptoms inhibiting or stopping you from doing activities of daily living or either working? If they're not, be very cautious about undergoing procedures. Now, here we go with a lot of Black people on this. All right. And the question is, why do I show them and why do I show atypical? The reason I show atypical is because most Black people have either no symptoms, which we believe are actually atypical symptoms, or they're having symptoms, but it's not the usual symptoms we talk about. They're not having claudication or cramping in the leg that actually happens with walking and then improves with rest. They're not having those. Many times Black people also don't have pain in their feet and cramps in their toes where they have to dangle their legs. They're not having that. So what kind of symptoms do they have? Does anyone know what this is? Do you remember earlier I said I pointed out a varicose vein? Here's a varicose vein here. These are other spider veins that's actually on the feet. Now, the reason I share this is because this atypical pain / no pain is actually because they're having symptoms related to another condition. And so what happens with varicose veins is the blood starts to pool in the leg. And if you think about carrying weights around on your leg, no one wants to walk with ankle weights all day unless you're an athlete, right? And so what happens is your legs start feeling heavy. They can feel tired. Their ankles can get swollen, okay? You can start to have other symptoms such as burning, numbness, tingling in your legs, because all that inflammation, that swelling in the leg starts to damage even your nerves, okay? And so varicose veins have often been shown in my practice to be associated with peripheral arterial disease. As a matter of fact, when I looked at 80 patients in my practice that actually were diagnosed with arterial disease, about 74% of them, and the majority of them were white, actually had venous disease underlying the arterial disease. So it's important to know that just because you have arterial disease doesn't mean that you don't have another condition. Another condition that can be commonly associated with arterial disease or can be a misdiagnosis is pain. So here we have bones of the spine. We have a disc, herniated disc you hear about. Sometimes that disc can impinge or push against the cord. Sometimes the nerves leaving the cord can get harmed by bones surrounding it, and it can result in pain, burning pain shooting down the back of the thigh, back of the calf. Now, some doctors may say, wow, you have arterial disease. You may not have arterial disease. It may just be sciatica. But again, in some patients that may have had a car accident, some injury where they were lifting a lot of weights, old football injuries, athletics, they may have sciatica that's also associated with arterial disease. So we don't know, but we need to know that atypical pain or having no pain does not mean the person doesn't have arterial disease. They may have it, they may not have it. So again, in Black people, we're seeing symptoms that aren't always the traditional arterial disease symptoms of claudication or rest pain. We hear about diabetic neuropathy. Just because someone has diabetic neuropathy, and yes, you can see this person has varicose veins as well. Many of these symptoms, whether it be arterial disease, overlap venous disease, or vein problems, overlap nerve problems. And what you can see is many of these symptoms are the same. And so it really have to be with a provider that understands this and is not misdiagnosing someone. It's not misdiagnosing means they're giving you the wrong diagnosis, and it's not a misdiagnosis means you have arterial disease and they just haven't diagnosed you with it because they haven't taken the time to do the correct examination. So again, we're talking about Black people in particular. We fill up a lot of this group of atypical pain, and that becomes related to vein problems that can overshadow or mask presence of arterial disease. Sciatica can do the same, as well as diabetic neuropathy. Now, why is this important here? Because you have someone purple, because guess what? They've been treating everything in the patient except for what needs to be treated. And we want to make sure that as Black people, that we avoid being the purple man in the bed or the purple lady in the bed. We want to make sure that we're getting the right diagnosis and the right treatment. So now the question is, why do we need to detect the disease? Now, I actually gave this away earlier. I said because the first place that we usually detect the disease earlier is where? Is it in the neck? No. Is it in the heart? No. I said it's in the legs. Again, where's the first place we usually detect the disease earlier? It's in the legs. So if we can detect the disease in the legs sooner, we can start people on risk factor modification. That is diet, that's exercise, that's making sure we can control all the risk factors of diabetes, high cholesterol, rheumatology problems, hypertension with medication management, okay? And nowadays, we're talking about Ozempics, right? And Rybelsus and all these new medications. We're talking about those medications reducing inflammation in the body. And that's where we are now. So how do we take disease in the legs now? So I know we have some physicians here, and they're going to tell me, they're not going to tell me ultrasound, they're going to tell me to put some blood pressure cuffs on something. And they would be correct. We put blood pressure cuffs on the arms, and we put blood pressure cuffs on the ankles. And the reason we do this is we want to compare the pressure in the arm to the pressure in the legs. And by comparing the pressure, it lets us know if there's a drop off in blood flow anywhere between the heart and where we check the pressure. The blockage could be here in the aorta, that abdominal artery. It could be in the artery that leads to the legs, the iliac artery, or it could be in some of these leg arteries, okay? So this allows us, the blood pressure allows us to detect the changes between the arm pressure and the leg pressure. What you see in the left column is actually how we do it. It's a math problem. So to check the pressure, the index, that's what we want to get, the pressure in this leg, we take the highest right ankle pressure and we put it over the highest arm pressure. Again, if we want to do it, the left ABI, this is the ankle, the arm, the ankle, the brachial, B is the arm, brachial is the arm, so the ankle, arm, index. And by doing that, it'll give us a number. Now we know that the highest pressure tends to be in the leg. So let me give you an example. Let's say that Ms. Johnson had a blood pressure of 135, top numbers 135 in the arm, but in her legs, the pressure is 62. Like, wait a minute, that's a large drop in pressure. Why would her leg pressure be 62? Or let's make it easier. Let's say it's 20. Well, Miss Johnson has some big problem where the blood pressure is too low in her legs. So she must not be getting blood flow through. That's why we use this calendar. That's why we use this chart. So if the blood pressure is too low, usually less than an index of 0.9, so you put the ankle pressure over the arm pressure. If it's less than 0.9, or Miss Johnson with a 20 pressure and 130 in the arm, she'd probably be here with severe disease. What this suggests is you don't need to compress this blood pressure. You compress it just a little bit, it's going to close off her artery. So that means she's not getting just a trickle of blood flow in there. But now let's look at the other hand. On the other hand, if Ms. Johnson's pressure is 130 here in the arm, but her leg pressure is 260 here, or really 250, right? You'd say, wait a minute, Ms. Johnson's pressure is so much higher in the leg. Are her arteries just that much larger that it just takes so much pressure to constrict it? The problem is Ms. Johnson may have all that plaque. Remember that yellow stuff I showed you that was narrowing the artery? That's what she may have. And now that calcium can turn to almost like bone, that calcium. And so now it's like compressing a steel pipe, and it's hard to compress it. It may get to the point that here it says non-compressible. The arteries may be so damaged with plaque and calcium that you can't compress it. And this means the index is going to shoot up greater than 1.3. And we're going to say, Ms. Johnson, there's a problem here. You probably have very bad disease, and there's a problem. There's possibly a risk that if we don't get this resolved, you can be at risk for amputation without good medication management. Now, here's a problem, though. There's a problem. The problem is that this does not work in people with diabetes. Okay? I'm going to say this again. This does not work well in people with diabetes. And you ask, well, why doesn't it work in people with diabetes? Because their vessels tend to be very heavily calcified. So let me ask you a question. If the vessels are really heavily calcified and it takes forever and you can't compress it, you can't do the study. You have no idea what the problem is. Now, let me ask you another question. Do you believe that the vessels can be so calcified that they almost are so narrowed that you can then just press it a little bit and it closes the vessel off? Absolutely. People with diabetes may start off normal. They move into what's an incompressible vessel, means it's just so tight to compress it. And then they go back down to normal, and then they move into where you can't get any blood flow through. So with them, it's almost like they go up into non-compressible, then they come back down into normal, and they come back down into severe arterial disease. This is why you cannot rely on an ABI in patients that have diabetes and also kidney disease, because kidney disease and diabetes tend to affect these lower leg arteries. Again, should we rely on an ABI, an ankle pressure in a patient with diabetes or kidney disease? No, we should not. So again, ABI is not and should not be used in patients with diabetes and kidney disease, because if you catch someone that has been non-compressible and they're now back down to normal, you're thinking they're normal, and then 6 months later, guess what they have? Severe arterial disease, and you missed it. We don't want to do that. So how do we detect it? I'm glad you asked. Guess what blood vessel is one of the last ones to get heavily calcified? It's the toe arteries or the digital arteries. So these toe arteries are smaller, and they tend to be the last blood vessels to get heavily calcified. Again, heavily calcified vessels mean it's hard to compress them. So we want to compress vessels that are not heavily calcified, and we can do that many times in digital arteries or toe arteries. And so any study that you get from your doctor, okay, if you have diabetes or your family member has diabetes or kidney disease, you tell the doctor, no, sir, I have been educated by a vascular surgeon, and he said that you need to add on a TBI. So if ABI means ankle, brachial is the arm, so ankle, brachial or arm index, ankle arm index, then what's a TBI? Toe, B is for brachial or arm. Okay, so if you want to call it in your terms, I want an ankle arm index. You want to say that? Because you don't remember the word brachial, then say it. I want an ankle and I want an arm index. If I don't have diabetes or my family member does not have diabetes and kidney disease, but if they do, you want a what? I want a toe arm index. Okay, toe brachial index or TBI, or a toe arm index. Okay. Now, I gave you a lot of information. Gave you a lot.
So I asked Simon to hold that so we can have a little discussion on this extra information that Dr. Kendrick has given us. And we want to complete this at a later date. But there's so much information here. I didn't want to go through the whole program without a chance to discuss some of it. There's a machine that some of us use in our office called a pseudomotor machine, where we look at ABIs and TBIs. And I want to discuss how we use those. This excellent lecture on how to prevent unnecessary amputations. Dr. Neighbor Stevens and Dr. Hind, you care to comment on anything so far?
Well, I thought it when we had him live, and I still think it, and I'm glad we have a few minutes that we can talk a little bit about this. He did give an excellent explanation, and I think he did an excellent job making it understandable to the layperson. But I am suspicious that there are some other ways or reasons why people wind up with end-stage vascular disease that we might want to talk a little bit more about. He didn't emphasize them as much, but I believe that they are really some of the more common drivers to the problem. What am I talking about? He mentioned sores or in the diabetic foot, and that you see in diabetics, but you also see what's called stasis ulcers in people with peripheral vascular disease. And that's the end stage. What we want to emphasize is trying to prevent from getting to that point. And what are some of the reasons people get to that point? If they have the underlying conditions that put them at risk, let's talk turkey now. We just had Thanksgiving. Let's just talk turkey here.
Or mac and cheese.
If you are a diabetic and you have not come to an agreement with your treating physician as to how your treatment is to progress. And I'm echoing something that Dr. Walks said a few weeks ago. It needs to be a treatment agreement. It does not need to be, should not be I'm telling you to do A, B, and C. There needs to be a conversation, and there needs to be an agreement on a treatment plan. If after you have come to this treatment plan, you proceed not to follow it, then you are setting yourself up for a whole range of complications. But we're talking today about amputations. So I'm here to tell you, if you do not understand the importance of being adherent, I'm not going to say compliant, but adherent, which means you are following the treatment plan that you and your provider agreed to, you're setting yourself up for an amputation. Now let's talk about stasis ulcers. He really didn't talk about that at all. And people with peripheral vascular disease frequently wind up with these sores that just don't heal, and they get bigger and bigger, they get infected, and they go through rounds and rounds of antibiotics and frequently wind up with amputations. Again, you need to understand and agree to a treatment plan and follow it so that you don't wind up at that end stage. I'll stop there and turn it over to my adult doctor colleague, Dr. Hines.
So I think everything you said is on point. As you were talking, I was thinking about, the treatment plans, right? And the concept that many of us set out with these, we have these goals. For example, some people may have gone to Thanksgiving dinner with a plan, right? And a plan that said, I'm not going to overeat, and I'm not going to, not going to have too many desserts and all of those kinds of things. And some people might have been able to stick with it. And others not so much. But to your point, I think some of it is about, do you truly understand, and are you truly understanding the consequences of some of the decisions that you make? When it came to things like peripheral vascular disease or heart disease or some of the long-term consequences of some of the chronic conditions that are popular in the Black community, oftentimes I will tell my patients, yeah, I need you to understand where this goes, right? What are the complications that are down the road? Because once you have them, there's nothing I can do really to get rid of them, right? And I don't want you to get there and say, no one told me that this could happen. No one told me that, you know, my legs, my toes, my eyes, my kidneys, my heart, my brain, all these things were at risk. And I think sometimes that part gets lost in dealing with the now, and folks don't understand always very clearly the real potential there for life-changing, even if your life isn't over, right? Life-changing consequences from uncontrolled conditions. I also think that sometimes too, when we're talking about, for example, like stasis ulcers and other things, sometimes I wonder if folks are getting the follow-up, you know, the time frame and follow-up that they need to keep some of these things from getting to end stage places before they end up higher on the radar, especially things that don't cause pain, right? Sometimes the things that don't cause pain or that are not causing you discomfort don't always get that precious time. You got 15 minutes maybe, right, in your doctor's office. And the thing, yeah, I have this thing on my foot, on my ankle, on my toe, wherever, I have this wound that's not healing, but it's not hurting me, it's not bothering me. But I have these other things that I know I need to talk about that either bother me, or pills I know I need to get refilled. And sometimes those things that aren't causing immediate discomfort get put on the back burner, even though they're extremely important. Because the other thing about wounds that don't heal is peripheral vascular disease is only one of the things that could be wrong with a wound that's not healing, or something that's not, progressing like it's supposed to. But those are the things that came to my mind. Again, this talk was very, very, very informative, and I love his presentation style as far as keeping it very clear, so that everyone can understand.
Well, what you remind me of, Dr. Hind and Dr. Neighbor Stevens, is an old church song. The leg bone connected to the ankle bone, the arm bone connected to the wrist bone. The body is one thing, and everything is related to the other thing. The blood vessels are all related. The way you eat, your diet, your health, your exercise. There is no just one thing to single out. Everything works together. And we've talked about diet, we've talked about exercise, but all comes together. And he made it very clear how these things work. The other part that I thought Dr. Neighbor Stevens was going to go to, and I saw something on TV the other day where a gentleman was told that his family was told that he was brain dead, and he was going to the surgical suite for organ donation, and turned out that he was telling them that he wasn't dead and they were still going to take his organs. And somehow they stopped it. And he got discharged from the hospital, went home, and he's not perfect, but he's still in shape. And this happens even more with people of color. And this suggests to me that whenever you start your health journey, a lack of health journey, you need to have a loved one, a trusted one, a family member or something with you every step of the way. And you need to have what do they call those things you write before you die?
A will?
No, not a will.
Advanced directives?
Advanced directive. And you need to make sure that there's somebody you don't have too much insurance that they're going to be wealthy off of, but you have to be very careful. I'm in a profession as a nephrologist where we encourage people to donate kidneys, but I've always been hesitant. of donating organs, even though I may not shouldn't be saying that, because I've seen where they don't look kindly on Black people, and they may take your organ to pronounce you dead before it's your time. So, and I think some of the reasons that these unnecessary amputations happen is that they're very profitable to the hospital and to the doctor. So I think those precautions are something we have to look at. I think we're at the top of the hour, and I know we're in the holiday season, but I want to come back to the rest of this talk at a later date. I asked Simon to mark the place on it. I want to finish Dr. Kendrick's lecture and maybe even have him back on it. This is very important. Let's talk about final words. And Dr. Hines?
Well, again, I think that one of the things that we talked about here today was being an advocate, right? And being clear and having knowledge that you can also take to your provider to say, hey, to make sure that you all are coming up with a strategy that is the best care for you. And I think that's probably one of the things that I wish we could have all along for our various issues, to be able to know the language enough to be able to ask for, hey, should I be getting this test? Because, I might be a better candidate for this test. Remember, doctors are people, right? And that means we're human, and that means we make mistakes too. So bringing your information to the table is not a bad thing.
Thank you. Dr. Neighbor-Stevens.
Dr. Lawson has his hand up.
Dr. Lawson?
Yeah, I just want to bring up some quick points. One is right now there's high popularity of martial arts, Taekwondo, Brazilian Jiu-Jitsu, all of it. And almost all require that you go barefooted. And unfortunately, too many of our folks go, the exercises are good, but they don't check the feet. And I've seen excellent folks end up, because they don't check the feet, end up with amputations because they let these things happen. Because they definitely keep up the exercise, but at the same time, put on a sock or something else. The other thing is that I've had several professionals, and Dr. Maxey knows them well. We like to work, especially those who do not have hospital practices, 12, 16 hours a day, sitting down and not moving. And I've seen lots of folks, a lot of our professional folks, lawyers, physicians, especially African Americans, who we tend to work beyond what we need to do, end up with amputations just because of disuse and inactivity.
Thank you, Dr. Lawson. I was bragging about you today. You always have wonderful words of wisdom. Thank you. Dr. Neighbor-Stevens?
Thank you. My closing thoughts are, I guess I feel very strongly about this, and usually whatever I think goes across my face. I've never been able to control that very well. But I see so much of this disease of diseases that have led to the end stage of amputation, especially among members of our community, that I can just only urge everyone to deal with whatever you have to deal with in terms of access to care specifically, and make sure that you get the appropriate care that you need. Do not say, this can wait. This can wait. Go in for your checkups. Especially the older you become, the more necessary it is for preventive maintenance.
Dr. Neighbor-Stevens, I thank you for that. Can you unmute Dr. Lamont Gibson? He has something in the chat. Is there any way you can show that real quick? What he put in the chat, Simon? He wanted you to put it on. Dr. Lamont Stevens, Dr. Gibson.
I just launched it.
Is it being shown? Simon? All right, well,
Okay, I had it going. I clicked it from the chat. So everyone can actually enjoy it even after the session by simply copying it. There it goes.
Hey, happy birthday! Happy birthday! Oh, hey, happy birthday! Yes, to you. Hold up. Who? You, Max, that's who.
Wow.
Hey! It's Max's birthday! Happy birthday!
Happy birthday,
wow.
So just remember, a day without a laugh is a day totally wasted.
Thank you, Dr. Gibson. Thanks, everybody. Have a great, great Sunday.
Ciao.
All right.